Hello and welcome to my Opthal teacher, and we're going to discuss about viral keratitis today. Our last lecture was about bacterial keratitis, and subsequently we'll be discussing about fungal keratitis also. So viral keratitis is corneal inflammation caused by viral infections. Now the major viruses that are causing keratitis are HSV1 and 2, varicella zoster virus, both of which are DNA viruses, and adenoviruses, which causes local outbreaks of conjunctivitis. So, among the viruses causing keratitis, as I've told you, these are the DNA viruses, and they are responsible for more than 99% of cases of viral keratitis. And then there are some other viruses as well. Now, we will confine ourselves to herpes keratitis and the adenovirus keratitis today. In herpes, we'll be talking about both herpes simplex and herpes zoster. So these three viruses, rather HSV virus and varicella zoster virus is the one that is important for you. So etiology is the herpes simplex virus, which is of two types, 1 and 2, the ones that are responsible for human infections. It's a double-stranded DNA virus that belongs to the herpes virus family, and it has a tendency to lie latent in the ganglia that are present, such as trigeminal ganglia for the HSV1 and sacral ganglia for the HSV2. It's a neurotrophic virus, means trophic. The word trophic means it has an affinity for the nerves. And it is also epitheliotropic, means it has an affinity for the epithelium. So the initial infection is characterized by the virus, the double-stranded DNA virus, entering the epithelium, multiplying and causing a primary disease. After that, it travels retrograde through the nasociliary nerve and reaches the trigeminal ganglion, and it lives there only to become reactivated by some stressor, and then it travels anterograde back to the cornea, say if cornea is the target organ, back to the target organ and causes a recurrent infection. There are studies which have shown that it might lie latent in the corneal stroma as well. So it is mostly the ganglia, maybe the corneal stroma. So this on the left side is your primary infection, and on the right side is the recurrent infection. It is the recurrent infection which is the notorious one. So HSV type 1, there is a rule of thumb that HSV type 1 causes infection above the waist. So we'll be discussing the ocular HSV today, and that is mostly HSV type 1. And HSV type 2 is the one that causes infections below the waist or genital herpes. Clinical manifestations of herpes simplex ocular infection. So it can be congenital or neonatal ocular herpes, primary ocular herpes, and recurrent ocular herpes. This is the ocular herpes caused by herpes simplex in general. It is of the following three types. So congenital and neonatal ocular herpes, just a brief overview. It can be intrauterine peripartum, postpartum. Mostly it is postpartum, and this is what it looks like. There are vesicular skin lesions. So these typical vesicular skin lesions may heal with or without scarring, and they are the prototype of these herpes simplex infections. Eye involvement can be in the form of conjunctivitis, keratitis. There may be oral lesions, and rarely it may involve CNS and multiple organs. So the treatment is topical antiviral for the skin lesions. So 1% trifluridine. Trifluridine is commonly used in the US. In India, mostly we are using acyclovir, ophthalmic ointment, or rather acyclovir ointment for the skin lesions. And for disseminated disease such as CNS or multi-organ involvement, systemic acyclovir at a dose of 2 grams per day IV every 8 hourly for 14 days. Please remember this dose. It may be asked in your Viva. So coming on to primary ocular herpes, that is the primary infection when the HSV exposure happens for the first time, usually in childhood, 6 months till 5 years of age. That is some age group that is, more predisposed to primary ocular herpes, spreads by direct contact with infected secretions. So clinical features, now see, primary ocular herpes is usually a mild infection. So some skin lesions would be there, the typical vesicular lesions around the mouth, around the eyes, right? And inside the eye, it will cause an acute follicular conjunctivitis, often mistaken for adenoviruses. So all viral conjunctivitis more or less look similar. They are characterized by an acute follicular reaction and they are usually self-resolving in nature. Keratitis in cases of primary infections is rare, and if it happens at all, it's going to cause punctate or branching epithelial type of keratitis, which we will be discussing in detail further on. There will be no stromal involvement. Treatment, we know that the infection is usually self-limiting, and sometimes if you find that it is very severe, you can give an acyclovir 3% eye ointment in order to limit the corneal involvement if you feel that the cornea is beginning to get involved. Systemic acyclovir is rarely needed in primary infections. So once the primary infection heals, HSV travels along nerves to sensory ganglia. We saw that chart earlier. So possible latency in the cornea, yes, but usually what we know is that HSV infects the epithelium, reaches the nerves, and then it travels retrograde or reverse and goes and sits in the ganglia and lives there. Under certain stressors, certain environmental conditions, physical, mental stress, it kind of reactivates and then it travels back antegrade and leads to a secondary or what we call as recurrent herpetic infection. So we are going to discuss the recurrent herpes infection now, and that is what is notorious. So the dormant virus in trigeminal ganglion reactivates, travels down trigeminal nerve to cause recurrent infection. There are usually no systemic features. It is typically unilateral, frequently involves the cornea, unlike the primary ocular herpes, which involves the cornea rarely and usually manifests as a mild follicular conjunctivitis. This one involves the cornea frequently. It can also cause retinitis, trabeculitis, uveitis, and optic neuritis. These are some other structures in the eye that may be affected. We are going to deal with keratitis today. The known triggers for reactivation of a latent herpetic infection are these: fever, exposure to UV rays, menstrual stress, so on and so forth. So overall, when we talk about viral keratitis, we discuss it under the following headings: epithelial involvement, stromal involvement, and endothelial involvement. So we are going to start with infectious epithelial keratitis. So infectious epithelial keratitis, now it's a type of recurrent ocular herpes simplex infection. Symptoms, I think all of you are familiar with the symptoms of keratitis. So the earliest epithelial lesion is in the form of these vesicles, you see, corneal epithelial vesicles or a superficial punctate keratitis. These small minute vesicles are there, and these vesicles, when they rupture, they lead to these superficial punctate keratitis. But many often we do not see patients presenting at such an early stage. What we see is this, okay, a dendritic ulcer. This is the characteristic lesion of recurrent epithelial keratitis, and it is caused by actively replicating virus. So as you can see, the lesion is more or less linear and dichotomously branching, two branches given off just like a tree, and each branch ends with a terminal bulb. Please remember, it's an ulcer, right? It is caused by the breakdown of the epithelium. So the floor of the ulcer, which is an epithelial defect, will be fluorescein positive. The margin of the ulcer, we know that there are actively replicating virus particles. So the margin is the part that contains the actively replicating virus or the infected epithelial cells. And remember, infected epithelial cells or diseased epithelial cells stain positively with rose bengal. So a dendritic ulcer floor would stain with fluorescein, whereas margin would stain with rose bengal. So now you know the principle underlying the stain. So you will remember what stains what structure as we proceed through the lecture. And it is on the basis of these stains that different infections are, different epithelial infections are differentiated from each other. Some other features: marked diminution of corneal sensations. So corneal sensations are, this is a hallmark that corneal sensations are diminished markedly in herpetic infections. Please remember that. There may be subepithelial haze and there may be a follicular conjunctivitis. What you see here is a dendritic ulcer in the lower part of the cornea, and this dendritic ulcer has now enlarged in the upper part to become a geographic ulcer. So that is the next feature, Geographic ulcer. So what happens when these different dendrites or branches, they fuse to each other? The entire overlying epithelium breaks down. There is a large defect with actively replicating virus particles at the edges and a large, amoeba-like ulcer in the center. So geographic ulcer is nothing but an enlarged dendritic ulcer, okay, which looks like this. And it has scalloped borders because the virus is sort of eating away at the epithelium at the margins of the ulcer. And usually a dendritic ulcer would convert into a geographic ulcer under these conditions, that is progression of dendritic ulcer in immunocompromised or steroid misuse or untreated long-standing disease. Now the treatment of recurrent epithelial herpetic keratitis. So the definitive therapy is to minimize scarring and inflammation. See, a herpetic epithelial infection usually heals spontaneously. The sole purpose of treatment of epithelial herpetic keratitis is to minimize scarring and inflammation, or in other words, to minimize the corneal stromal involvement. We don't want the infection to go deeper. So we give topical antiviral drugs. So acyclovir 3% ointment, you have to know the concentration of the ointment and the duration. You cannot forget this. Then acyclovir is 5 times a day. Ganciclovir 0.15%. It's in the form of a gel. It is also 5 times a day until the ulcer heals, and then 3 times a day for 5 days. Try fluorothymidine drops 2 hourly until the ulcer heals with vidarabine ointment. So please try to remember at least acyclovir and ganciclovir topical ointments. These are also available in our country. Then mechanical debridement of involved area. This is true for any other ulcer also. So mechanical debridement of involved area with a cotton tipped applicator helps remove the poorly adherent infected cells. It decreases the viral load from the epithelium and promotes healing. Systemic antiviral drugs are usually given for about 10 to 21 days, and they include acyclovir, famciclovir, valacyclovir. Okay. Again, remember acyclovir 400 mg BD TDS, and valcyclovir, which is actually a pro drug of acyclovir, is 500 mg BD. Then there is this non-supportive therapy. Non-specific supportive therapy consists of artificial tears, cycloplegia to reduce the pain, dark goggles again to reduce the pain to prevent photophobia, vitamin C for healing, systemic analgesics and anti-inflammatory, rarely needed in epithelial keratitis, and topical antibiotics if there is a superadded bacterial infection. Now, persistent epithelial disease. When would you call it persistent epithelial disease? If, despite treatment, the epithelial disease, that is a fluorescein stain positive, is persisting beyond 2 to 3 weeks, that is labeled as a persistent epithelial disease. What are the causes? If it is a metaherpetic, that is a non-infectious condition, we'll be discussing it subsequently. If the person is resistant to antivirals, or if there is drug toxicity. Now see, all these antiviral drugs, they are basically interfering with the DNA synthesis. So they also affect the normal cells. And that is why they have a lot of surface toxicity when used for a very long time. So keep drug toxicity in mind always. And these drugs should not be used when they are really not needed, such as in the cases of pure stromal or endothelial keratitis. Unwarranted use of these drugs is not justifiable. So that completes our infectious epithelial keratitis. Now we'll be talking about neurotrophic keratopathy or metaherpetic ulcer. So basically, the difference between the previous type of keratitis and this type of keratitis, both being epithelial keratitis, the difference is that this one does not contain actively replicating virus. This is basically a cornea which has gone bad because of the virus particles, right? The virus is now dead, but the epithelium is for some reason not able to heal. So this is termed as trophic if arising de novo, such as neuroparalytic keratopathy, or neurotrophic keratopathy, as in trigeminal nerve paralysis because of some cause, then that would be called a trophic keratopathy, neurotrophic keratopathy. And if it is arising because of a pre-existing dendritic or geographic ulcer, then you call it a metaherpetic ulcer. But the term is a misnomer. There is no herpes in it. Okay, there is no active herpes virus in it. So no live virus, and the poor epithelial healing because of, you have to know these factors: drug toxicity, loss of innervation and neural growth factors, poor tear surfacing, and underlying low-grade stromal inflammation. What are the signs? You see, it's a very dry corneal surface. This part of the cornea has some luster, whereas this part does not. So, lusterless cornea, an oval shaped ulcer with smooth but thickened borders. Remember the scalloped borders that you had seen in cases of geographic ulcer. This one has smooth borders. And because these borders do not contain active virus, they only contain heaped up epithelium. This epithelium is not able to migrate over the defect and cover it. So that is the main pathology. How to differentiate it from geographic ulcer? Now, one difference, the one morphological difference is that that one was scalloped borders and this one was smooth borders. Another difference is about the staining. Now, see, in this case, the margins would be fluorescein positive, whereas the base would be rose bengal positive. Why so? Because the base contains unhealthy unhealthy epithelial cells which are trying to migrate, which are trying to cover up the defect. So the rose bengal dye would still stain these cells which are abundant in the base of the ulcer, right? So that explains the rose bengal positivity of these ulcer base. Now what happens if you put fluorescein? What is going to happen is that these epithelial cells, as we know, are defective, right? So fluorescein is going to leak through these defective epithelial cells and leak through these cells and leak into the surrounding stroma, such that the margins would take up the fluorescein stain. The margins which consist of a healthy stroma. Outside that margin of heaped epithelium, you will find that the fluorescein dye has leaked into the stroma and accumulated. Okay? So I hope you have understood the staining pattern, right? Why rose bengal is staining the base of a metaherpetic ulcer but not a geographic ulcer. Complications that can happen with the metaherpetic ulcer are stromal scarring, necrosis, perforation, and secondary bacterial infection. And yes, this phenomena is known as reverse staining. So I think you can make that out. Why it's called reverse staining? The mainstay of treatment of a metaherpetic ulcer or neurotrophic keratopathy is to protect the corneal surface and remove any underlying cause that is preventing the epithelium from healing. So we can do a gentle debridement. Stop the use of toxic medications. Sometimes it is the topical antivirals themselves which are not allowing the epithelium to heal. So stop these medications temporarily. Observe the patient, it might improve. Punctal occlusion to increase the tear film. Again, tear film supplements, bandage contact lens, amniotic membrane grafting, tarsorrhaphy, or the last four are all to protect the corneal surface. Now we come to stromal keratitis. The first entity in stromal keratitis is immune stromal keratitis. So this is found in 20% patients with ocular herpes simplex virus. And basically, immune stromal keratitis, as the name suggests, it is a reaction to the viral antigen, an immune reaction to the viral antigen that is present in the corneal stroma. So since it is a stromal involvement, because of intrastromal viral antigen, the overlying epithelium would be intact. Stromal infiltration is there because it is an immune reaction, so there will be stromal edema. There may be an immune ring also, again, which is a ring of infiltrate. Sometimes this immune ring would not be as prominent as in this picture. It might be incomplete also. Mild AC reaction. Why mild? Because the primary site is the stroma. So a mild AC reaction and sometimes stromal neovascularization, new blood vessels growing in to the corneal stroma, and then we call it interstitial keratitis. So this is one of the differential diagnosis of interstitial keratitis, and the prototype of interstitial keratitis is actually syphilis. Please read up syphilis related interstitial keratitis and Cogan syndrome, because syphilis is a emerging disease. So you have to read about syphilis related keratitis now. So anyway, in this case, the differential diagnosis, in this case, it is interstitial keratitis caused by herpes virus. So there will be stromal neovascularization, and when the the reaction subsides, these vessels may persist as ghost vessels. Complications, it can cause disciform keratitis, that is, it can go further and involve the endothelium, or it can cause scarring. So treatment, again, the mainstay of treatment is topical steroids, because after all, it is an immune mediated inflammation. So it will respond to steroids. Topical, maybe systemic. Systemic antiviral, simultaneous oral antiviral prophylaxis is recommended. It has been found in the herpetic eye disease study that it decreases the risk of HSV reactivation thereafter. Topical antibiotics if needed, lubricant and cycloplegic if needed, systemic steroids if needed, but it is extremely rare. So the mainstay of treatment is topical steroids in immune stromal keratitis. Next, we have necrotizing stromal keratitis. Now, here again, necrotizing because there is an active virus in the stroma. So this is because of viral replication in the stroma, and also it can be immune mediated. Both the things are there. So it is characterized by stromal necrosis, melting a dense infiltrate, a dense anterior uveitis with a lot of KPs, and KPs and inflammatory cells infiltrate the trabecular meshwork, clog it, they cause trabeculitis and resulting in secondary glaucoma. So this is a very complicated sort of ulcer, and it looks like, as you can see from the picture, it looks like any other microbial ulcer. It is very difficult to differentiate. Unless you know the history of the patient, it is very difficult to differentiate. What are the complications that can happen? The complications, these are the complications as can be seen in any other type of microbial keratitis. So the treatment, now this type of stromal keratitis, since it contains antivirus, since it contains active virus, it needs aggressive antiviral therapy, both topical and systemic. And it also needs a corticosteroid use because there is an immune element also, and their inflammation is too severe. So aggressive antiviral therapy along with corticosteroids in minimum tolerated dose, minimum possible dose. Topical antibiotics and cycloplegics, and if there is perforation, you have to manage the perforation accordingly. So that's about the stromal keratitis. Coming on to endothelial involvement or endothelitis. Now, the prototype of herpetic endothelial involvement is the disciform endothelitis. The other two are rare entities. We will not be discussing them. Disciform endothelitis is so called because it looks like a disc. Why? Because there is localized endothelial dysfunction due to inflammatory response to viral antigen, resulting in a disc-shaped area of corneal edema known as disciform keratitis. So again, it is an immune reaction. Since the endothelium is involved, there will be KPs, there will be decimate folds underlying this area of stromal edema, right? Stromal edema would happen obviously because the endothelial is an endothelium, the endothelial pump is failing. So there will be a localized area of endothelial dysfunction, as a result of which there will be overlying stromal edema and immune infiltrate. So that will manifest in the form of decimate folds and granulomatous KPs. Sometimes you may have an immune ring of Wesley also, and it is very important to differentiate disciform endothelitis from Fuchs dystrophy. Fuchs also present in a similar way, but the difference is that Fuchs is bilateral and this one's unilateral. And of course, there are other differences related to the herpetic infection. So you look at these KPs and see how localized they are. So these are the mutton fat KPs of herpetic endothelitis. It may be accompanied by trabeculitis with the resultant glaucoma. Herpetic uveitis is basically causing sectoral iritis because of live virus released into the aqueous from sympathetic nerves. This is what is hypothesized. Now, if there is an anterior uveitis, it can lead to complications, and these are the complications of any anterior uveitis. So unilateral uveitis associated with high intraocular pressure should raise a high suspicion of HSV. Why high intraocular pressure? Because of the coexisting trabeculitis. So that is very typical of herpes. Treatment. Now again, this is immune mediated. There will be topical steroids and there is active virus. It is hypothesized that an active virus may be there. So you will give antiviral cover also. Anyway, if you are giving topical steroids, the topical steroids have to be in the minimum possible dose and with antiviral cover. You can give cycloplegics for comfort. Of course, you would need cycloplegics because there is an anterior uveitis. If it's an active epithelial lesion, you may need to give a more frequent antiviral regimen with a very low steroid dose. The steroids have to be gradually tapered to avoid recurrences. Oral steroids may be given if there is a severe stromal involvement or if you have to avoid topical steroids because of IOP elevation. Please read about the herpetic eye disease study. There was herpetic eye disease study 1 which was done in 1989 and there was study 2 which was done in 1993. So the recommendation of the herpetic eye disease 1 study was related to stromal keratitis, and it states that if you give topical prednisolone to patients of stromal keratitis, there is faster resolution and fewer treatment failures. And there is no additional benefit of adding a systemic antiviral in cases of stromal keratitis. HED2 trial included the epithelial keratitis. So it says that in cases of epithelial keratitis, there is no additional benefit of adding a systemic antiviral. And systemic antiviral will reduce the risk of ocular herpes in the near future by 40 to 50%. Okay, so please read up about heads 1 and heads 2 studies. So when would you want to give a prophylactic antiviral? You would give a prophylactic antiviral in cases of patients with multiple recurrences, that is 2 or more in a year, those who have scarring close to the visual axis, those who are using topical corticosteroids for stromal disease for a long time, and those who are systemically immunocompromised. So this is where you need systemic prophylaxis. And what do you give? You give acyclovir, used at a dose of 400 mg twice daily. Now this is different from the therapeutic dose of acyclovir, which is 500 mg 800 mg 5 times a day. Please remember, therapeutic dose 800 mg 5 times a day, prophylactic dose 400 mg twice a day. Just some of the antiviral medications used in the treatment of ocular herpes. So basically we are mostly we use acyclovir and valacyclovir. Trifluridine is mentioned everywhere because it was the drug used in US. And of course they have adverse effects because of their mechanism of action. They affect the normal cells also. So that was all about HSV1 infections. HSV1 is the virus that causes ocular infections and not HSV2. HSV2 is the one that causes genital infections, and it is very rare that it is causing ocular infections, such as in cases of vaginal delivery. When if there is an HSV2 infection in the mother, it might get transmitted to the baby and manifest in the form of vesicles on the face and so on and so forth, but that is extremely rare. So let us talk about herpes zoster ophthalmicus. Primary infection in early childhood as chickenpox happens. It is a nearly universal. So basically kids are affected with chickenpox and then they acquire immunity from it. If not, if acquired in infancy or adulthood or immunocompromised or by the immunocompromised, it can be a fatal infection. It is very severe. So what happens is that this varicella zoster virus, it becomes latent in multiple ganglia simultaneously, and then it reactivates as a vesicular rash, which presents as shingles. This rash is accompanied by a very, very severe pain. So the point number 2 and point number 3, this becomes the rationale for developing vaccines against herpes zoster in general, not herpes zoster ophthalmicus necessarily. So there are 2 vaccines. One is a live attenuated chickenpox vaccine, okay, which decreases the incidence of varicella related hospitalizations in this population by 75%. And the other is a shingles vaccine, which is a higher dose of the same attenuated virus, which reduces the incidence of herpes zoster and related neuralgia by more than half over a period of 3 years. So the shingles vaccine is now recommended for all individuals over the age of 60. So herpes zoster ophthalmicus, see, this is an elderly lady. So she must have had a viral prodrome. The viral prodrome is followed by an abnormal sensation in the affected dermatome, followed by a maculopapular rash, which heals, which goes through the stages of vesicles, pustules, and finally heals by crusting. Remember the Hutchinson sign and the rule, that is, if the tip of the nose is affected, that is the Hutchinson sign, and if the tip of the nose is affected, there will be an ocular involvement. This is the Hutchinson rule. It is not a rule of it. You can say that it's a rule of thumb, but it's not universal. Okay. Remember, VZV can also cause all these, manifestations because it can affect any structure in the eye, right? Now, we will only be talking about VZV associated keratitis here. So it can be acute or chronic. Now, just as with herpes simplex, it can be involving the epithelium, stroma, and endothelium. It is very similar, but there are these differences which you must remember. So epithelial involvement in case of herpes simplex was dendrites. This one is pseudodendrites, which are usually seen in the corneal periphery and appear stuck on. Why are they called pseudodendrites? Now, these dendrites lack terminal bulbs and dichotomous branching, which was seen with herpes simplex, and they stain poorly with both fluorescein and rose bengal stain. That is why pseudodendrites. If stromal involvement happens, it is known as nummular keratitis. Nummular because they are coin-shaped lesions that appear in the superficial stroma, often underlying areas of previous epithelial keratitis. And just like immune stromal keratitis of herpes simplex, this is also immune mediated. And of course, there can be endothelial involvement in the form of severe keratouveitis and endothelitis, and sometimes even sclerokeratitis, which has to be differentiated from other causes of peripheral ulcerative keratitis. For example, Staphylococcus induced PUK. Chronic relapsing disease is seen in the form of mucus plaques. See, these are mucus plaques, and these mucus plaques also look like pseudodendrites. They have a stuck-on appearance, and you can easily scrape them off. But the underlying epithelium would be unhealthy. Okay, it is said that this may be a variant of filamentary keratitis. This is highly resistant to treatment. Multiple recurrences can lead to scarring. And of course, there can be disciform keratitis and interstitial keratitis also. This forms the chronic relapsing disease version of varicella zoster or herpes zoster ophthalmicus. Long-term complications include neurotrophic ulcer, similar to that seen in herpes simplex, but more profound loss of corneal sensation, even if a single episode of HZO had happened, and these ulcers are more likely to perforate. Neuralgia, as we know, herpes zoster associated neuralgia is very, very bad. It is debilitating. And by definition, pain that lasts longer than 1 month constitutes post-herpetic neuralgia. Treatment of herpes zoster ophthalmicus, oral acyclovir. Now see, the therapeutic dose 800 mg 5 times a day, 7 to 14 days, regardless of the stage of the disease. Oral steroids are controversial because on one hand, they may reduce systemic inflammation and pain. But if ocular disease is there, especially if epithelial, the disease can exacerbate. These are some of the drugs used for the treatment of post-herpetic neuralgia. So gabapentin is a common one. Okay. Others include carbamazepine, pregabalin. Antidepressants are also prescribed. Then topical drugs include capsaicin cream and lignocaine cream. And last, but actually the most common type of viral keratitis is adenoviral keratitis. It causes outbreaks of epidemic keratoconjunctivitis, and these are the viral serovars that are responsible. So keratitis is seen in about 80% patients. It presents as a punctate epithelial keratitis and usually resolves by itself. Like any other epithelial keratitis, it resolves in 2 weeks. Sometimes there are focal white subepithelial or anterior stromal infiltrates which look like this, and this is also again an immune response. So uncomplicated stromal infection is usually an immune response. Sometimes you may have small pseudodendritic epithelial lesions also. So this picture shows a follicular reaction, which is the same for all viral infections, and this is a subepithelial lesions. So the treatment of adenoviral infections, you just have to let it be. Give a lot of lubricants for symptomatic relief. Discontinue any contact lens wear, maintain hygiene, keep all the examination, all your instruments separate, sterilize them, clean them with povidone iodine, symptomatic relief with compresses, tears, or antihistamines, vasoconstrictors, and remove any pseudomembranes if present. That will again facilitate healing, right? So that's all about the viral keratitis. I hope a lot of your concepts are cleared, and thank you for watching.